Welcome to today's webinar, Be an HPV Vaccination Champion, co-sponsored by the California Department of Public Health and the American Cancer Society. Continuing education credits are being provided by PACLAC. I'm Jane Pazua, health educator with the California Department of Public Health Immunization Branch. For audio, all participants should be using the call-in number and participant passcode shown on this slide. All lines will be on mute during the teleconference. Today's call will focus on new ACIP recommendations for HPV vaccine, evidence-based parent communication strategies for recommending HPV vaccine, and resources available to support your practice and quality improvement activities and patient education. By the end of the call, participants will be able to describe new ACIP HPV vaccine recommendations, explain at least one communication strategy shown to effectively motivate parents to obtain HPV vaccination for their children, and list 3 resources available to support HPV vaccine quality improvement activities. Continuing education credits will be available to healthcare professionals licensed in California listed on this slide who attend today's live webinar for its full duration and complete the online survey provided at its conclusion. Please be aware, if you are seeking CEs, you must register and log in individually so we can verify that you attended the entire webinar. Throughout the call, you may ask questions at any time by typing them into the Q&A panel at the lower right-hand corner of your screen. Please address your questions to all panelists as shown here. This slide shows where you can find the Q&A panel. We will also provide the opportunity to ask live questions at the end of our webinar today. After the presenters have completed their program, we will answer as many questions as possible. We have 3 wonderful presenters today. Our first speaker is Dr. Eileen Yamada, Public Health Medical Officer in the Clinical and Policy Support Section of the Immunization Branch at the California Department of Public Health. She provides technical assistance for local health departments, healthcare providers, and other programs on clinical immunization topics. She is a fellow of the American Academy of Pediatrics and a member of the American College of Preventive Medicine. Our second speaker, Dr. Noel Brewer, is Professor of Health Behavior at the University of North Carolina. He is chair of the National HPV Vaccination Roundtable. Dr. Brewer studies health behaviors, including HPV vaccination, cancer screening, and smoking. Our final speaker is Dr. Marcy Fisherborn. She serves as the Director of HPV Vaccination for the American Cancer Society and Principal Investigator of the HPV Vaccinate Adolescents Against Cancers Project, a national initiative to improve HPV vaccine rates through evidence-based quality improvement interventions in federally qualified healthcare centers and through other key clinical, state, and national partnerships. Drs. Yamada and Fisherborn have no conflicts of interest to disclose. Dr. Brewer reports the financial relationship disclosed on this slide. I'd now like to turn it over to our first speaker, Dr. Eileen Yamada.
Thank you, Jane. Today I'll be going over briefly the new ACIP 2-dose HPV vaccine recommendations and also provide a little background on the new recommendations. First, I'll start out with California immunization rates. First of all, Healthy People 2020 objectives for adolescent immunizations are a target of 80%. For California, the data I'm presenting today is from the National Immunization Survey team for California for 2015, and this is for 13 to 15-year-olds. As you can see here, our rate for Tdap vaccination is 87%, well exceeding our Healthy People 2020 objective of 80%. For the meningococcal conjugate vaccine, we're close to meeting our 2020 objective. But when you look at our rates for HPV vaccination, you can see here that for 3 doses of HPV vaccine in females, we only have a rate of 42%, and for males, only 29%. And even looking for our rates for 1-dose HPV vaccination, the rates are far lower than our other adolescent vaccines. Dr. Noel Brewer will provide some wonderful communication strategies to help improve our rates of immunization for HPV vaccine. Next slide. So today, only HPV 9 is being distributed in the United States. It was first licensed in December of 2014, and the licensure was expanded in 2015 so that the licensure was for both females and males ages 9 to 26 years. Most recently, in October of last year, data was reviewed for a 2-dose series, and the licensure was expanded to include a 2-dose HPV series for persons 9 to 14 years. So the studies that ACIP, the Advisory Committee on Immunization Practices, looked at to determine their recommendation for this 2-dose schedule, looked at studies comparing 2-dose schedules versus 3-dose schedules, and they looked at all the HPV vaccines, the bivalent, the quadrivalent, and the 9-valent vaccine, because we can learn a lot from some of the longer-term studies in the bivalent and the quadrivalent vaccine. In each of these studies, there was a comparison group, usually older women, where efficacy was demonstrated against persistent infection, cervical and other precancers, as well as genital warts. And what these studies found that the antibody response after 2 doses in our younger age group, typically around 9 to 14-year-olds, was non-inferior to the response after 3 doses in the older age group. When data was looked at, there were some studies that looked at 2-dose schedules and 3-dose schedules in that younger age group. And although results varied a bit by trial, the antibody titers were lower sometimes after 2 doses compared to 3 doses for some of the HPV types. So now I'm going to concentrate on our 9-valent HPV vaccine data. This slide here shows geometric mean antibody titers 1 month after the last dose, and it's comparing girls who are getting the 2-dose series at 0 and 6 months in blue to women getting the 0, 2, and 6-month schedule in yellow. And as you can see here, the geometric mean antibody titers 1 month after the series are generally higher in girls than women, and in fact, it meets the non-inferiority criteria, and in fact is statistically significantly higher for the younger girls, as you can see here, from 1.6 to about 3 times higher. We also have some data that looks at the same data over time. We have data right now up to 6 months, and we find that the GMTs continue to be higher 6 months after that last dose. This slide here looks at both girls and boys at a 0 and 12-month schedule compared to women at a 0, 2, and 6-month schedule. Again, it looks at geometric mean antibody titers 1 month after that last dose. And similarly, you can see the younger girls and boys who got the 2-dose series in blue have higher GMTs than women who got the 3-dose schedule in yellow. In fact, it varies from about 2 times to over 6 times the amount higher in that younger age group getting the 2-dose series. This slide shows seroconversion rates, again, 4 weeks after the last dose, for girls, boys getting the 2-dose series at 0 and 6 months, and also 0 and 12 months compared to girls and women getting the 3-dose HPV vaccination series at 0, 2, and 6 months. As you can see here, the seroconversion rates are uniformly high in all populations, and when you look at seroconversion rates in the 2-dose series, it meets the non-inferiority criteria. So we have data for the 9-valent vaccine out to 6 months, and we saw that it was non-inferior at that point, looking at the 2-dose series compared to the 3-dose series. But we have longer-term data for both the bivalent and the quadrivalent data. So this slide shows the data for the quadrivalent HPV vaccine, looking specifically at titers for HPV-16, and it compares the 2-dose and 3-dose series. What you can see here in red, you have the 3-dose series in the younger girls, 9 through 13 years of age, and that's the highest. The next line below that is in dark navy blue. It represents the 2-dose series in girls 9 through 13 years. And at the bottom, you see a green line, and that represents the antibody titers in women 16 through 26 years who are receiving a 0, 1, and 6-month schedule. And as you can see here, the antibody kinetics over that 36 months remains similar. It tends to peak right away about a month after completing a series, and after that you see a decline in the antibody titer, pretty much plateauing at around 18 months at that point, with basically the antibody titers remaining higher in the younger girl population getting the 2-dose series compared to women getting the 3-dose series. So in terms of duration of protection, ACIP also looked at the data we had for the bivalent and the quadrivalent HPV vaccination series, looking at 3-dose schedules. And we have data out to 10 years right now for both of those vaccines. And looking at the data, there's really no evidence of waning protection after 3 doses. And when you look at antibody responses, they remain maintained over those 10 years. In terms of 2-dose schedules, we don't have that long-term antibody protection data from the 2-dose trials. But as you saw earlier, the antibody kinetics were very similar with the 2-dose and the 3-dose schedules, which suggests a very long duration of protection after 2 doses. So now I'll move on to the ACIP recommendations. And they really haven't changed. Routine HPV vaccination continues to be recommended at age 11 to 12 years. And it's also may be given as early as 9 years of age. And this includes providers who are using VFC vaccine as well. They may immunize any patient as early as 9 years of age. And HPV vaccination is recommended specifically starting at 9 years of age for children with a history of sexual abuse or assault. Catch-up vaccination is also recommended for females through 26 years and males through the age of 21 years if they haven't been adequately vaccinated before. Males 22 to 26 years may also be vaccinated. And there's a specific recommendation through the age of 26 years of age for men who have sex with men, for transgender persons, or persons who are immunocompromised, including those with HIV. So when we look at the recommendation for the 2-dose schedule, who is supposed to get that schedule? So basically, it's based on when the person initiates vaccination. So anyone who's initiating vaccination starting at age 9 through 14 years, as long as they're immunocompetent, are recommended to receive the 2-dose series. And the second dose is recommended to be given 6 to 12 months after that first dose. For persons who are starting the vaccination series later, at 15 through 26 years, they're recommended to get the 3-dose series at 0, 1 to 2 months, and 6 months after that first dose. Immunocompromised persons are also recommended to get the 3-dose series regardless of their age. One thing of note is to understand what the minimum interval. As you're scheduling patients, you should always use a recommended dosing schedule, the 0, 1 to 2 months, and 6 months, and then 6 to 12 months after that first dose if you're using the 2-dose schedule. But you probably have a lot of patients in your practice who may have gotten 1 or 2 doses in the past. It's important to look back when you're looking at 2 doses and 3 doses. You want to make sure they meet the minimum interval to determine whether their series is valid. So for the minimum interval for a 2-dose schedule for those starting at 9 through 14 years of age, the minimum interval is 5 months between the 2 doses. When you're looking at the 3-dose schedule, the minimum interval between the first and second dose is 4 weeks. The minimum interval between the second and third dose is 12 weeks. And the minimum interval between the first and third dose has been updated, and it's now 5 months. Previously, it was 24 weeks. I just wanted to clarify the recommendation for 3 doses for immunocompromised persons. All immunocompromised persons are recommended to get a 3-dose series, regardless of age. And ACIP defines immunocompromised persons really those persons with reduced cell-mediated or humoral immunity, because it's likely their antibody titers would be lower than immunocompetent persons. And this includes persons perhaps with HIV infections, with cancers, or who are on immunosuppressive therapy. One thing of note, it does not include those with complement component deficiency or asplenia or some of the other conditions at the bottom of the slide. I'll go through a few cases just for you to kind of hone in your knowledge of the two-dose schedule. So an 11-year-old boy in our practice received the first 2 doses of the HPV vaccine series 2 months apart, according to the 3-dose schedule. Can we consider his series complete? No, he would need a 3rd dose, because people have received 2 doses of the HPV vaccine, even if they're less than 15 years of age. If the 2 doses are separated by less than 5 months, they should receive a 3rd dose and complete a 3-dose series. The 3rd dose should be given at least 12 weeks after the 2nd dose and about 6 to 12 months after that 1st dose. Okay, the next case, a girl in our practice received the first dose of HPV vaccine when she was 14 years of age. And then the 2nd dose was given 5.5 months later when she was 15 years of age. Can we consider her series complete? So in this case, yes, you can consider her series complete because she started the series. Remember, it's when they start the series, not when they finish the series, before the age of 15 years of age and met the minimum interval of 5 months between dose 1 and 2, so that her series can be considered complete. So that's all I have today, and I want to thank everybody for their attention. This is my email here if you think of some questions after the webinar today, but I'll go ahead and pass the microphone back to Jane.
Great. Thank you very much, Dr. Yamada, for that update on HPV vaccine recommendations. And I will now be turning it over to Noel. And just one moment. Thank you for his presentation on parent communication strategies. One moment.
Hi, folks. This is Noel Brewer, and can I have a reminder on how I move the slides forward?
Yes, I'm trying to do that. Oh, there we go. Pardon me for that delay. You should have control now.
Thanks so much. Oh, there we go. Control. Okay. All right. Hi, folks. I'm going to talk today about a way to more effectively recommend HPV vaccination to patients. I have on this slide some of the disclosures that are in addition to the ones that were on the earlier slide. I've received industry research money from industry, from the federal government, as well as from foundations. This is an important number, 56%. It's a number that stands out for the nation. The corresponding number for California is 60%, a little under 60%. It's the number of kids who have HPV vaccine. It's kind of amazing. We've crossed a really important line. More kids have received HPV vaccine than have not. We've really made huge strides. As we heard earlier, though, there's a long way to go. HPV vaccine is certainly the norm now. It's what parents do. It's what most parents do. And yet we still have to be thinking about going beyond just a single dose and getting to the 3rd dose, or in some cases the 2nd dose, completing the HPV vaccine series. So glass half full, glass half empty. We have, sort of 2 ways to look at it. I'm really happy that we made these strides, but we also have these problems, these challenges to address. One thing I want to have you all think about is what the guidelines say. We've heard the guidelines, but I want to reinterpret them very slightly. The idea of giving 2 doses at ages 11 or 12 is what it means to give on-time vaccination. That's according to guidelines. That's when the vaccine is likely to be most effective. That's when the body's, children's immune systems mount the strongest response. Giving HPV vaccine at later ages is late. It's not a catch-up dose in my mind. It's what we're doing when we're giving HPV vaccine late. So timely vaccination is certainly very important. Now, in our mind's eye, this is what it looks like when we anticipate giving HPV vaccine to a child. There's going to be someone who's alarmed, there's a needle somewhere that everyone's freaked out about, and that something just uncomfortable is going to happen. Parents, adolescents, adults, healthcare providers all have this image in their mind to some extent, but what can we do about it? Are there ways to get past that? Well, here's some data here that show what's on healthcare providers' minds. The one issue is that about a third of them expect the conversation is going to be uncomfortable, and it'll be uncomfortable specifically because they're going to have to talk about sex. Second, these healthcare providers believe that parents don't want HPV vaccine, even though indeed parents do want it, and apologies for the typo there, parents, not patents. Third, they think the HPV vaccine discussion is going to take a long time, and it is true that it will take longer for HPV vaccine to get discussed than the other vaccines overall. However, the times that they expect are really quite a bit longer than is happening in reality. So it is possible to spend less time than expected and also just less time than currently folks are taking. Finally, one of the challenges is that healthcare providers discuss HPV vaccine last. They just discuss it in a hesitant way, or they discuss it not at all. Much of the research on this slide is from Melissa Gilkey at Harvard, who was part of my group at the time. Now, HPV vaccine recommendation quality is certainly quite variable. When we asked a national sample of pediatricians and family physicians whether they recommended HPV vaccine at ages 11 or 12 for males, 39% of them said no, they didn't recommend it in a timely manner. They recommended it at some later age. For females, 26% said they recommended it at some later age. In terms of the strength of their endorsement, 27% gave a ho-hum or a lackluster recommendation. In terms of consistency, recommending it across the board by age, not based on some other criteria, fully 39% of these physicians preferred to pick and choose who they recommended to based on their assessment of the child's risk. And then finally, urgency, recommending same-day vaccination. Fully 40% of physicians recommended HPV vaccine at some later date, but not at that visit. These are all really problematic quality indicators, showing that we have real problems with HPV vaccine recommendations in the nation. And I think they reflect some of the challenges that healthcare providers at least imagine and potentially even experience. I'm going to today recommend that we consider a different recommendation style, a different way of going at things. So these are data from the National Immunization Survey team, of data for 4,121 parents of female adolescents. The data show the following. Presumptive announcements were rarely used. Only 1.5% of visits were presumptive announcements used. Instead, healthcare providers were using participatory approaches or fully these intense conversations going back and forth. What's interesting, though, is that these announcements were the most effective, looking at the HPV vaccine initiation data based on physician and healthcare provider verified records. So this presumptive announcements done in this efficient way, that yielded the highest vaccination rates. An informed approach, quite a bit lower rates, in fact not that much different than not giving any recommendation at all. So using an efficient approach may have some promise. So I'm going to give you some data right now from a randomized controlled trial where we trained physicians and other healthcare providers on how to recommend the HPV vaccine in an efficient approach using these presumptive announcements. The first step is to announce the child is due for 3 vaccines, and hopefully that leads to HPV vaccination. I'm going to go through with those some details about that announcement step. If needed, then the physician or healthcare provider went on to ease the main concern about HPV vaccine, recommend the vaccine strongly, and then if that didn't lead to HPV vaccination, to ask the parent to return. Okay, so here's a little bit more about what the announcement training was about. This first step, we recommend that the healthcare provider note the child's age, then announce the child is due for 3 vaccines recommended for children this age, placing HPV vaccine in the middle of the list. Say you will vaccinate today, and that is key. And then finally, move on to the visit. So this is what it looks like, or actually what it sounds like. I see here that Michael just turned 11. Because he's 11, Michael is due for meningitis, HPV, and Tdap vaccines. We'll give those at the end of the visit. So note here we've noted the child's age, and that sets things up. Then we note the 3 vaccine the child is due for. Meningitis is first, HPV is second. And then we note we're going to vaccinate today. We'll give those at the end of the visit. Here's an alternative version. Now that Michael is 12, there are 3 vaccines you give to kids his age. Today he'll get meningitis, HPV, and Tdap vaccines. Okay, so that's what the training looked like, the first piece. And each of these additional pieces have a little bit of a script that goes along with them. If you're interested, you can look in the paper that we published in Pediatrics. I'll give a reference for that in a little bit. But the second piece is that if parents don't go along with vaccination, for whatever reason, they may have questions, they may be uncomfortable, which is fair. Let them ask their questions if they want them. You certainly want to create that space if they raise an issue. Regardless of what they raise, you come back to them and say, well, okay, really, what's your main concern? Parents may have a big troubling boogeyman in the back of their head that they can't quite fess up to early on, but if you create space for that, they can. Then regardless of what they say, you in a neutral way acknowledge that in a completely open-minded way, and then say, well, here's what the science shows, and then you explain to them why the vaccine is important. Finally, then you recommend the vaccine strongly using some kind of motivational statement that summarizes why you think it's important, and then saying the words, I recommend, so the word recommend, and then today. All right, so that's the first trial arm. And then remember, this is from a randomized controlled trial, so there was a second arm in which physicians and other healthcare providers were trained to have a conversation. So they would start a conversation that went back and forth. They would dredge up any possible concerns and keep going and going and going, eventually give a strong recommendation, and hopefully that would lead to vaccination. Here are the results. Now remember I said there were 2 arms. There was a announcement training and a conversation arm. There's also a third arm where clinics didn't receive any visit at all. I've subtracted the pre-test vaccination rates here, the baseline rates from the rates at follow-up, and the data right here are for the 6-month follow-up. Then we also have subtracted out here the change for the control group. So this orange bar here for the announcement training is the increase in the announcement training group above and beyond the group, the clinic that had no visit at all. That shows there's a 5% increase as a result of training clinicians to use presumptive announcements, and that is statistically significant. The conversation training in gray, however, did not show any increase in a statistical sense, so that 2% is not distinguishable from 0. So announcements compared to conversations are important. We also showed changes among females and males, so the approach was effective for parents of both sexes of children. The conversation training was effective for neither sets of parents. These are data, as I mentioned before, that have been published in Pediatrics. I'm also happy to send a copy around. You'll see my email address at the end of my presentation. Okay, so people liked this training a lot. 100% would recommend it to a colleague. 93% plan to routinely use this communication strategy. My favorite quote is this: it's easier for parents, it's easier for us. Those of you who are looking to do quality improvement work, I want to encourage you to consider using existing materials. Save your time for the actual quality improvement efforts, but the creation of new materials is not really necessary. We don't need to try to make something up on the spot. We don't live in a dorm room. We don't need to use our tennis rackets as colanders. There's lots of lovely, shiny new materials out there, and those include the ones on this slide. CDC maintains a terrific set of resources for healthcare providers. The American Academy of Pediatrics has a great HPV champion toolkit. The family physician, as well as nursing associations and physician assistant associations, also maintain resources. Finally, this resource on the right-hand side, developed by the HPV Vax group at the American Cancer Society, I very strongly recommend taking a look at that if you're going to start an HPV vaccine quality improvement project in your clinic. In terms of highly endorsed brief messages for those recommendations, that recommendation step, these are ones that stood out and did really well with parents and physicians in terms of being endorsed as being likely to increase HPV vaccination. So for that third step where you strongly recommend the vaccine and you give a motivational statement before you say I strongly recommend it, here are 2 statements. I strongly believe in the importance of this cancer-preventing vaccine for Jacob, is one statement. And a version of that was developed by the CDC. This other one, Emma can get cervical cancer as an adult, but you can stop that right now. The HPV vaccine prevents most cervical cancers. That was developed by our team and also, beg your pardon, developed in consultation with a pediatrician in South Carolina. Another thing I'd like you to keep in mind if you're going to be developing a quality improvement program across your office, and I strongly recommend that you do, is that there's a peak in vaccination that happens in the summer months in June, July, and August. And that if you're going to create a quality improvement program, it's best to promote to parents during that period of time. If you want to do trainings for physicians and other healthcare providers, you want to do that a little earlier, April, May, and June. If you want to really rework the system, really break things in a way that's going to be disruptive, do that in November, December, and maybe January when the vaccination rates are lowest. This picture here shows in red a normalized vaccination rate across all states. Your state is somewhere in here. All 50 states show up in the gray lines. I'll also mention briefly the National HPV Vaccination Roundtable. It's a coalition of organizations working to prevent cancer by increasing HPV vaccination. The role of the roundtable is to convene organizations, to exchange information, to find gaps, and to catalyze efforts not achievable by any one organization. We especially focus on connecting vaccination to cancer prevention efforts. I strongly encourage everyone on the call, if you're not already connected to your state immunization branch or to the physician or other healthcare provider organizations, connect to those organizations. They're really outstanding, and those two together are quite powerful. So in summary, HPV vaccination is the new norm. It is simply what the majority of parents are doing. We need now to get more of them on board. On time and late, 11 and 12-year-olds, vaccinating 11 and 12-year-olds means vaccinating on time. Vaccinating after that is late vaccination. It is a low-quality approach. It is an approach that will be potentially less effective in preventing disease and perhaps even reaching all the people you want to reach. Vaccinating early is the key, early or at least on time, but not late. Announcements work. Presumptive announcements saying your child is due for these 3 vaccines, we'll give them at the end of the visit, is a terrifically effective approach. We recommend promotion in the summer for vaccination efforts that reach directly to parents, a little earlier than that for reworking training for provider training and so on. However, systems changes in the winter. Use existing materials to the extent that you can. We gave examples earlier on, and then partner with key stakeholders in the immunization branch, in immunization coalitions, and also in the state healthcare provider organizations. So hopefully that will help you all get to an easier conversation with patients as well as their parents, that we can have respectful, appropriate conversations that are really quite a bit quicker. And that's one of the things we found by using presumptive announcements, that we solved a problem that healthcare providers have, that people were more at ease and it was taking less time to have those same conversations, and it was more effective. Thank you very much. Here's my contact information if you need it.
Great. Thank you, Dr. Brewer, for sharing with us your research on parent communication strategies. I am now going to pass control over to Marcy to turn it over to our final speaker. And you are ready to go.
Okay, great. Well, hi, everybody. Good afternoon. My name is Marcy Fisher-Bourne, and I am excited to be sharing with you some practice resources that will hopefully be useful to you, to clinical systems, to partners that you may have in the state of California. And I'll just say, before I start, that I love Noel's slide with the tennis racket and ravioli. There's no reason to do that. There are so many resources, some wonderful national resources, some incredible California-specific resources, and I'm going to be going over those briefly. Before I do, just to give you a little sense of our work within the American Cancer Society, I lead our VAX project, which has multiple layers, including quality improvement, clinic-specific interventions, focusing on adolescents 11 and 12, focusing on systems change work. And I just want to highlight some pieces of that so you have a sense of the context. So Noel mentioned working with your immunization branches, your immunization coalitions, your provider associations in the state level. I'd also love to encourage you to work with ACS, particularly our state health system staff, and we have one in every state. Raquel is on this call now, as well as our primary care staff. And our primary care health system staff within ACS work on a clinic level, helping coach practices through change around cancer prevention. And in the case of HPV vaccination, really helping them implement quality improvement projects that are going to be evidence-based and help them as they begin to understand and track their data to see change within a clinical system. And as we started this work, we've been in 30 clinical systems representing roughly 300 clinics around the U.S. 3 of those clinical systems are in California and have really seen some tremendous change in the first 6 months of our project. So very quickly, our aim with the work of the VAX clinic interventions is really to set up a 12-month process where clinical systems first assess capacity through an inventory assessment process and then begin to implement specific interventions based on their needs, so whether that's provider prompts or parent reminders. When we first started this work in the first 3 months, we trained roughly 1,800 providers. Since that time, we've trained almost 5,000 providers through small individual clinic-level trainings around HPV vaccination uptake efforts. And just to give you a sense of where we are with tracking success, early on in the first 6 months, we've seen a rate change of around 11.6%. So really promising in terms of some of the change that we've seen. Noel mentioned our steps guide. The way that we've structured our change has been largely outlined in this particular tool. So really encourage you to go to the bit.ly link to download this toolkit and to think about how it might work in your clinical practice or with partners. So just to give you a sense of what's in this guide, this is a 4-step process with steps 1 through 3 really helping clinical systems to understand their capacity to implement evidence-based interventions, and I'll walk through these steps shortly. The other thing I want to say just in terms of an orientation is that this toolkit is really about outlining the core evidence-based interventions for HPV vaccinations and doing so through a quality improvement framework. Within each step, so step 1 is assemble a team. Within each step, you will find a list of electronic resources, not all ACS. So mentioning the APA toolkit, CDC resources. For every step along the way, there are hyperlinks that will take you to those tools. So around assembling a team, what does it mean to create a quality improvement team? How do you improve capacity when you're looking at quality? All of these resources are combined in sort of a one-stop shopping location. Step 2 is around making a plan, so really identifying what are the core opportunities within this clinical practice, within this system that need to be addressed. What are the baseline numbers that need to be understood? This process has typically taken 3 months to really understand where is the clinic with their rate data, and to really begin to hone in what is our strategy. The third step is around making a plan. So in addition to preparing clinicians, one of the things we've learned through our intervention projects is the importance that all clinical and non-clinical staff in an office setting are engaged, are invested, and are working towards the change around improving rates. And finally, the step 4 is really about outlining the core intervention strategies that we think are going to move change. So focusing on making that effective recommendation, prompting the provider, looking at opportunities such as shot clinics to increase access, making sure there are processes in place to track series completion, to track follow-up, and in a continuous process for measuring and improving performance on an individual provider level, on a clinic level, and on a systems level. So that's the steps guide, and really hope everyone on this call takes down that bit.ly link and accesses that resource. Another resource that was created by ACS involved a specific provider audience. It's called Just the Facts, and it looks at some of the core concerns that have been raised around the vaccine, but reframing it around facts with talking points and with resources in terms of citations for what the evidence is around safety, around issues with fertility, around why focusing on 11 and 12. So that's another resource that's available to you. Finally, another resource, and this is through our HPV vaccination roundtable, of which Noel is chair. there's a wonderful state-by-state survivor speakers database. So we know that, I believe, in looking at some of the data that are shared, I feel moved, I feel compelled, but we also know that people need stories and they need context. And so having and engaging survivors in the process to reduce HPV-related cancers has been incredibly powerful for our work. If you are interested in having a speaker, an oropharyngeal cancer survivor, or a cervical cancer survivor, this is a great database for you to go identify specific organizations whose job is going to be to find you that speaker in an area that can meet that need. So a great resource. We've used it at ACS, and it's a fairly quick turnaround. I think within 24 hours when I was looking for a speaker in the state of Georgia, a throat and neck cancer survivor, we were put in contact with an individual. So incredible resource out of the roundtable. This is a CDC-specific resource, and Noel will share with you an image of some of the print material pieces, but really encourage you to look at the updated You Are the Key slide deck. Wonderful resources, lots of detailed notes to walk you through what each slide is communicating in terms of core information about HPV, about the vaccine, about the importance of 11 and 12. So print materials, this is the hyperlink is in the green box here, and I'll just say that these are available in multiple sizes. You can order them up to 25 for free in color, and most of the posters that are available both in English and in Spanish. Another important provider-specific tool, it used to be called Tips and Time Savers. It's now called Talking to Parents About the Vaccine, but it has these wonderful little thought bubbles. If a parent says, how do you know the vaccine works? Here's what you can say. If a parent says, you know, what vaccines are actually required? Here's how you can respond. A really important tool to share with providers. And finally, I want to just say a little bit about some of the patient-specific resources that are available specifically in California. The first is a photo novella called An Ounce of Prevention. And let me just make sure I'm telling you all the parts that I want to tell you about that. This is aimed at the Latino audience to deliver specific messages about the vaccine via a story. How important is the HPV vaccine as a flyer? It's available in English and Spanish, and it uses a father's personal story around losing his daughter to cervical cancer. Oh, great. That's right. Someone's clicking. There you go. It's like, where are my images? There they are. The third resource, Did You Know HPV Causes poster. This highlights the different cancers that can be prevented through the vaccine in both males and females. So it's a great resource. And finally, looking at the reminder cards, particularly providers using these cards to remind patients of when they are due for their next appointment. And, oh, can you go back one slide? There we go. One last piece, those are a few resources. There are even more through our National Roundtable Clearinghouse, which is at the bit.ly/HPVVax, where you can search for specific resources by audience and by population. So I encourage you, if you want even more resources, to access that clearinghouse. And I think I'm going to turn it back over to our organizers to open it up for questions, comments.
Thank you. We will now begin the question and answer session. If you would like to ask a question, please press star followed by 1. You will be prompted to record your name. Again, to ask a question, just press star followed by 1.
I just want to say thank you, Dr. Fisher-Bourne, for summarizing all of those great resources available to clinics to support them in their quality improvement activities. And thank you for that announcement as well, operator. And as she said, it's time for a Q&A session. So please press star 1 to ask a live question. We'll get started with a couple that we have that came in through the Q&A panel. The first question, is HPV vaccine required for school entry?
I'll go ahead and answer that. For California, Immunization requirements for school differ by state. So I'll speak to California. For California, HPV vaccination is not required for school entry.
Great.
Go ahead.
No, go ahead, Noel.
I think it's very important for healthcare providers not to fall into the trap of answering the question, is it required or is it just recommended? When you've done that, when you've adopted that framework in response to a patient question, you've already lost. I think it's important to take charge of the conversation by saying, I strongly recommend all 3 of these vaccines. The folks at the State House, your school, may have opinions about what they do or don't want to do, but I'm in charge of your child's health, and I'm strongly recommending all 3 of these.
That's great advice. Thank you, Dr. Brewer.
Yeah, it was part of the training. The training we did had a whole lot of different things in it, but that was one of the things that we think is particularly important. It is a challenge that healthcare providers have in recommending a vaccine.
Yeah, and I'll have to just add to that is in California, most of the vaccine requirements were put into place by the legislature. They weren't ones that we chose, that they were any better than the others. So we recommend all ACIP recommended vaccines. So we recommend that, you know, the 3 vaccines, adolescent vaccines equally. So anytime I think it's the requirements are for school, it's almost like a little placeholder that hopefully they get it into their pre-team visit, and hopefully they'll get all the vaccines recommended at that time.
We do have a question.
Oh, great.
Sorry, we do have a question on the phone lines if you'd like to take it.
Please, thank you.
Thank you. And again, just press star followed by 1 to ask a question. Our first question comes from Victoria Anderson. Your line is open. Go ahead with your question.
Yes, I was actually wondering if it's possible to get these slides emailed to me, because I wasn't able to view them. It said that there were too many people on the session.
Oh, well, thank you for persisting and listening despite the inability to view the slides. Yeah, we are aware that there was some sort of technical issue with that. Yes, why don't you, through the Q&A panel, just send your email address, and I'll get the slides to you.
Okay, thank you.
For those listening, these will also, this presentation will be archived as well on California's VFC website. It's eziz.org.
I'd like to answer a question that was emailed in advance of the presentations. There was a question about whether we should be using different approaches for different subpopulations. The data that we've seen across our studies and many other groups' research suggests that we need to use a single memorable approach, that adjusting the communication approach for folks who are lower literacy or people from one cultural background may not be helpful and may even be counterproductive. The approaches that I've described during my presentation were effective for broad, across many different groups of people.
Thank you for that, Dr. Brewer. Another question we have is, if the first dose was administered 1 to 2 years ago, should the vaccine series be restarted?
Oh, that's a good point. HPV vaccination, like any other vaccination, if there's been a pause or a break between after the first dose or after a second dose, you don't need to restart the series. So you can go ahead and start vaccinating with where you left off. So let's say someone got a dose at age 11, but they're already 16 now. They can finish the series with just 1 more dose. They don't need to restart the series.
Great, thank you.
We do have more questions on the phone lines if you'd like to take them.
Please, thank you.
Thank you. Our next question comes from Katie Wooten. Your line is open. Go ahead with your question.
Thank you. My question is, recently I had hosted a show for our providers of Someone You Love, the HPV epidemic, and then we had a panel with a pediatrician and some Merck representatives. And during the panel, I brought up the burden of oropharyngeal cancers, and the Merck representative was really quick to say the HPV vaccine does not protect against that kind of cancer. And so my question is, what is your suggestion in terms of promoting the vaccine for preventing those kinds of cancers? Because I was actually surprised by that. I didn't even realize.
I think what Merck responds to is they can only talk about what's licensed, so basically based on the studies. And so right now we don't have a good marker. Like for cervical cancer, we have a lot of information on, pre-cancers. Because when you look at all the studies, we're really looking at some of the more recent, the things that occur sort of right after infection. We're looking at infection, persistent infection. Then we're looking at cervical and other pre-cancers. So we can measure some of the pre-cancers in some of the other areas, but they're not able to measure that in terms of oropharyngeal cancer. They don't have something like the pap smear for oropharynx. So they can never say that it's going to prevent oropharyngeal cancer. I think, when we look at CDC, oftentimes what we can say is that HPV 16 and 18 and these other types can cause a certain percentage of the oropharyngeal cancers. And I think what Merck is responding to is they don't have a study on that because most of the time, the cancers don't occur for decades afterwards, and our studies have only gone for a certain period of time. So they don't have the data to state that. I think that's really what they meant. I think experts may think that, our vaccination may have an effect on the oropharyngeal cancer, but I think that Merck can't really state that because there's no specific study on that, of that specific outcome. It's really decades away.
I also believe that it's within a clinician's judgment to make a decision on how to speak about it. We know what's in the label, as you've said. We have anal cancer, cervical cancer, vaginal cancer, and vulvar cancer. We don't yet have the trials that will show us whether we can prevent oropharyngeal cancer, which is basically sort of the back of the throat. It's a very common, a relatively common cancer, quite a few cases in the U.S. relative to some of the other HPV cancers. So I think a clinician should feel comfortable speaking to that if they have a good grasp of the epidemiological evidence, and that epidemiological evidence suggests that the vaccine will likely be effective in preventing those diseases.
Thank you.
Thank you. Our next question comes from Laura Potter. Your line is open. Go ahead with your question.
Hi, thank you. I've been trying to design a program with some of my colleagues at the American Cancer Society to work with a clinic to improve their rates. And looking at a bunch of clinics' rates, it's really striking what the drop-off is between 1 dose and 3 dose. So clearly the physicians are having some kind of conversation that results in the 1 dose, and then after that it falls off steeply. And, I think we're just sort of assuming that it's unusual for people to need more than 1 vaccine in a relatively short period of time. And so it's a reminder problem. But I'm wondering if anybody's looked at that drop-off rate too, because if we could just get them, once they've given 1 dose, to complete it, that would be fabulous.
The data suggests that something like 70% of people who initiate the vaccine will complete the series, but I suspect that you're dealing with clinics that may have, maybe unusual, where there's maybe even only half or 25% or some relatively small number are completing. If that's the case, there may be some procedural issues to sort out, some structural issues. One of them might be the ability to schedule appointments in advance. So being able to schedule an appointment 6 months in advance is sometimes not possible to do, given the systems they have. They may want to look into that. That's one thing. A second is it may be that there's not a person within the clinic who's tasked with identifying who's due or sending some kind of reminder. So I would probably look into the specifics of how they handle this business of identifying people who are due for additional doses.
Thank you.
Hi, Laura. This is Marcy with ACS. I would just add to that within our clinical practices, we've certainly seen initiation being the primary area of focus. But for our clinical sites that we've been following for 2 years, we've seen fairly meaningful changes in dose 2 and 3 in the second 12 to 24 month window. So part of me also wonders if it's a matter of really figuring out where they want to start, and then being sort of vigilant as a practice coach around having them, as they begin to make progress in initiation, to think through the subsequent doses that are needed for completion.
Another question that came through the Q&A panel is, I've heard a lot of negative rumors about the HPV vaccine, such as side effects. How can we explain these to parents? Dr. Brewer, do you have any suggestions from your research?
So can I just clarify the question? So a patient walks in and says, there's something going on with the vaccine, I don't really know what. Is that the gist of it, or do they have a specific concern? My experience in talking with clinicians is that every parent who walks, the vast majority of parents walk in with something sort of vague. They don't really know what, they're just unsettled. And then among the ones who have a specific concern, it's really unique to that parent.
Yeah, this just said side effects, but I do know we have gotten other questions that were specific to fainting also. So I don't know if you can answer those together.
Sure. So across the world, we've delivered 200 million doses of HPV vaccine to patients. There are no serious adverse events that have been attributed to HPV vaccine in a causal way. We've never been able to establish that HPV vaccine causes this list of problems. There are ongoing conversations in different countries about concerns that parents have in places like Japan and Denmark and a few other places as well. But the science does not support any causal link with serious adverse side effects. In terms of shorter-term discomfort, that's true for all the adolescent vaccines. They can be a little painful at times in the couple of days afterward. In terms of the moments afterward, there is some data to suggest a meaningful number of patients, a few percent, may faint. So it's important to sit patients down potentially for 15 minutes from the time that you vaccinate for 15 minutes afterwards.
And this is Marcy. I would just add the facts document, which is one of the resources that we shared with you, goes through some of these points and concerns. So, for example, the point that Noel just made about safety, literally there's a talking point that says more than 2 million doses of vaccine have been distributed, 80 million of those in the U.S. While the safety is monitored, there have been no serious safety concerns. So, you know, I think keeping it short and sweet, that particular tool may be one for providers that are concerned about some of the questions. The facts tool came from us vetting what are the questions our staff are hearing around the country, and then turning those into a document that could be used by providers to very quickly address concerns.
Great, thank you for highlighting that. Operator, I think we have time for one more question.
We do have a question from Teresa Ortiz. Your line is open. Go ahead with your question.
I'm sorry, we seem to have a bad connection. Maybe you can try answering your question through the Q&A. Operator, do we have another question?
Okay. We do have a question from Priscilla Marcus. Your line is open. Go ahead with your question.
Yes, I'm calling from New Mexico, and my question is for children of 9 years of age. If the parent has a history of cervical cancer, would you recommend the HPV for that age group as early as 9?
I'm sorry, I missed it. Was it a certain population you were talking about?
This is for children 9 years for the HPV. If their parent had a history of cervical cancer, is that something you would recommend for that age group to give the HPV that early?
You know, you can choose to give anyone the HPV vaccine series starting at age 9. That's not a specific indication that you definitely should, but if the mother is asking for it at age 9 because of her history and would like to do that, I think that's a great age to go ahead and start. In fact, when you look at the antibody response, the younger you are, and I'm looking at 9- and 10-year-olds, your antibody response is actually higher than when you're, you know, even in that 11 to 12-year age group. So I know actually ACIP in the future is actually going to look at the recommendation, perhaps recommending it even at a younger age than 11 to 12 years. I don't know what they'll eventually vote on, but they are looking at that. But you can choose to give the vaccine based on today's recommendations to anyone starting at age 9. And I know some clinics, just for logistics-wise, to get basically all the immunizations in before they're 13 or before they're 12 years of age, they may routinely start earlier, and if that's amenable to the parents, that's a great thing to do because I think it will provide good protection, and more likely you'll be up to date before you're 13.
And the data suggests that the starting earlier means that children are quite a bit more likely to get the vaccine on time, and with the new 2-dose schedule, that's really imperative.
That's great. Thank you both for that. So we've reached the end of a very quick hour that we hope has provided clarity on HPV vaccine recommendations and evidence-based communication strategies and resources to increase HPV immunization in your clinic. Thank you so much to our speakers, Drs. Eileen Yamada, Noel Brewer, and Marcy Fisherborn. The American Cancer Society and the California Department of Public Health, thank you for spending your hour with us. Don't forget to complete the online evaluation, which will automatically come up after this broadcast to tell us what you thought of this webinar. The evaluation is required for anyone who wishes to obtain continuing education credits. Thank you again for joining us. Have a great day. Bye-bye.
Thank you. This does conclude today's conference. We thank you for your participation. At this time, you may disconnect your line.